Hello, my name is TannerDavis, and this is my DNP scholarly project titled Social Media and Practitioners' Antibiotic Prescribing Practices Related to Upper Respiratory Infections. I would like to take a moment to thank my project committee for their contributions, my project chair, Dr. Joanne Kern, second reader, Dr. Rita Wunderlich, and my community member, Nathan Moore, family nurse practitioner. Antibiotic resistance is among the gravest global health threats, killing 1.27 million people annually. It is also one of the most significant threats to food security, development, and overall health. Pressure from patients, misdiagnosis from providers, and lack of education from providers are standard issues leading toward overprescription of antibiotics. In one study, 93% of nurse practitioners rated online resources as the most useful for their knowledge of antibiotic prescriptions. This sentiment towards an online learning tool would likely improve providers' chances to utilize an online learning tool. The purpose of this DNP project was to evaluate if a social media education toolkit can reduce antibiotic prescriptions in patients aged 18 to 65 with upper respiratory infections. It also aimed to educate nurse practitioners on upper respiratory infections and why they typically do not require antibiotics, and it aimed to improve provider-patient encounters and patient education. Implementing educational interventions or antibiotic stewardship programs that include education as part of the program has been shown to reduce the number of prescriptions for antibiotics by providers. Patients and providers are both guilty of requiring more education. Providers are inadequately able to diagnose and treat viral upper respiratory infections, as these conditions account for most inappropriate antibiotic prescriptions. Examples of common upper respiratory infections include bronchitis, sinusitis, and pharyngitis. Amoxicillin specifically was found to be one of the most inappropriately used antibiotics among patients with upper respiratory infections, sometimes because of patient pressure. Providers could be attempting to treat pneumonia as it prevents similarly to bronchitis. The search for literature was completed through Maryville's library collection of about 130 databases. No studies that I've included declare a conflict of interest, and most of the included literature is comprised of cohort studies. These are the highest qualities of evidence, so that's a strength for the study. And an identified gap in the literature was I wasn't able to find a lot of literature surrounding social media as a tool for education. This project utilized Lewin's theory of change model. The first stage, according to the model, unfreezing, involves recognizing the need to change and what to do. This is where we recognize that antibiotics are being prescribed inappropriately. The second stage is called change, where plans are made and change is created. This is where we've kind of put the social media toolkit together and implement it And the final stage is refreezing, and that's where changes are reinforced, and that's where the changes that you made, you hope to sustain them. The planning phase of the project occurred between March 2023 and May 2023. Next, the educational materials were gathered for the toolkit from reliable sources in the forms of journal articles, posters, and YouTube videos to allow for a variety. This occurred from June 2023 to December 2023. Then IRB approval was obtained on December 18th, 2023. This allowed us to begin research. So recruitment of volunteers began on February 12th, 2024 within the NP Guidance group. That was the name of the Facebook group, NP Guidance Group. Educational materials were posted on the same day. And those, again, were journal articles, posters, YouTube videos, and occasional follow-up reminders were posted. They were posted each week for 2 weeks. And that was to remind participants to complete the post-survey at the end of the study. On March 25th, 2024, the survey was closed and the results were collected for data analysis. This is a flyer that was used to recruit participants in the NP Guidance group. It explains the purpose of the project along with the link to the survey within the Facebook post. So the actual link itself isn't on this flyer, but the link was above this flyer in the Facebook post. The inclusion criteria of the sample: participants had to be 18 years or older, be a nurse practitioner, be in the NP Guidance group, and have completed the survey to get in to Qualtrics. No identifiers such as name, address, email, or essentially any identifying information was collected from the surveys, and participants had the option to withdraw and exit the survey as well as the study at any time. And for the sample, it was anticipated that 154 nurse practitioners were going to participate in this study. That's not what we ended up with, but and the Facebook group that we pulled the sample from has 21,000 members. So we anticipated this 154 from that 21,000 members. This project used a quality improvement design using descriptive and quantitative data from a convenience sample. It used anonymous surveys for pre- and post-test design. This was accomplished online and through social media. The intervention consisted of posting the reliable educational resources to the NP Guidance group, allowing individuals to view the materials at their own leisure. Participants were encouraged to view the materials often in return for the 6-week post-survey. Completion of the pre-survey was only expected to take about 5 minutes. This survey is an adaptation of another survey as a means to collect patient demographic data, knowledge related to respiratory infections, and current prescribing practices. And finally, participants were reminded to return and complete the post-survey that closed 6 weeks later following the initiation of the study. This survey asked participants the same questions as the pre-survey with one additional question. It asked participants if they changed their antibiotic prescribing practices based on their participation in the project. And Qualtrics provided an anonymous link that can't be tracked to participants' profile on Facebook or an email address. The data that we gathered from Qualtrics was transferred to Excel for final analysis. This only took about $180 to complete, but it can be replicated for much less than that. There was minimal risk to participants feeling coerced. Participation was anonymous and voluntary. The data collected was downloaded from the Excel spreadsheet for final analysis, and it was downloaded to the researcher's password protected computer, and it was kept in the locked office that can only be accessed by the researcher. Okay. So this is pretty much the pre-survey data collection sheet. Up top here you have most of the demographic data and that kind of thing, and then you get into more of prescribing practices and that kind of thing. So like I said, this is the data collection sheet. This is the primary portion of the pre-survey aside from the consent. 16 voluntary and eligible nurse practitioners joined the study and filled out this data collection sheet. And here we have the additional question that is added to the end for the post-survey. Again, the post-survey was a repeat of the pre-survey 6 weeks later with this question attached. Only 5 participants returned for the post-survey. So 16 for pre and then 5 for post. The initial plan was to run a 1 proportional Z test for the data analysis. However, this was not possible because the 18 subjects that we needed to run the test was not met. And we needed 18 for it to be statistically significant. Instead, descriptive statistics were used to highlight what happened in this project. This first figure demonstrates the geographic location of the participants at the start of the study, as opposed to the time of follow-up. At the beginning, you can tell there's a good distribution between regions for, only 16 individuals. However, at follow-up, as you can see, only individuals from Midwest return, which can create some bias. The next figure demonstrates the percentage of participants that identify either male or female at the time of pre and then post-survey. Male participation was very limited before and after. So with this study, recruiting more males is definitely something that would need, to improve the study. Okay, and here's the data pre and post, comparing results pre versus post. So I'll kind of rattle off here a lot of the findings and a lot of the trends here that we saw. do a lot of the hard work here. The study demonstrated a 25% growth in the number of participants who selected no when asked if they would prescribe an antibiotic and schedule a follow-up if they do not have time to explain the causes for upper respiratory infection. A 6% increase was noted in individuals stating that they prescribe antibiotics based on clinical practice guidelines from pre to post survey. A 31% increase in participants stating they do not prescribe antibiotics to increase a patient's confidence in their medical skills when comparing pre to post surveys. A 37% increase was noted in the number of individuals that stated they would not prescribe an antibiotic for a patient that believes they need one based on respiratory symptoms. At the start of the study, 69% of participants stated they would not prescribe an antibiotic to a 25-year-old with complaints of acute sinusitis for a few days without fever, with exam of tenderness over the anterior sinus area. After completing the social media module and responding to the post survey, this percentage grew to 80%. However, I believe it's question number 11. At the start of the study, 94% of the participants stated that antibiotic treatment does not reduce the severity of upper respiratory infections. And at the time of post-survey, this number reduced to 60%. And half of the participants felt like the module did change the way they prescribe antibiotics, while the other half did not. Okay. The primary limitation of this project primary limitations were related to recruitment, retention, and the use of descriptive statistics. Only 16 individuals were recruited, with limited males. Additionally, less than 33% of participants were retained through the complete duration of the project. Finally, the project was limited in its use of descriptive statistics, which does not allow for generalizability of larger populations. So you can't make any kind of predictions about what might happen for larger populations. A possible barrier for this study might have been the fact that it was 6 weeks. This could have contributed to why only 5 people returned. If the study were to be replicated, you could potentially play with the follow-up time, maybe try 4 weeks and see if more people follow up, for example. Another barrier was a lack of similar research, as I mentioned before, specifically in terms of social media. The low budget is a great facilitator. There was no funding or anything needed to be secured by the researcher, like to complete the project. And the lack of structure required by the participants was another great facilitator to this project. And what I mean by lack of structure is that the project doesn't set a lot of rules for the participants. Like, it's social media, and there is no setting for the project. It's not in a specific building, so individuals just log on and complete education whenever is convenient for them. They don't have to complete a certain amount of education. They don't have to do a certain amount of hours and that kind of thing. So I think that attracts rather than repels participants. In the future, the participants could possibly be offered with monetary or non-monetary incentives to compensate for their time. At the start of the study, 94% of the participants identified as female, so efforts should be made to increase the recruitment of males. Additionally, materials within the module can be updated periodically to align with the latest research and evidence-based practices. And the module will be continuously evaluated to ensure that practitioners are learning about upper respiratory infections and changing their practices through the social media toolkit. And due to the promising results of increased provider knowledge, the next steps should be to attempt the study again and implement those changes that I just mentioned. The more the study can be repeated with statistically significant results, the better understanding we will have of the impact that social media toolkit has on the selected variables. In repeating the study, individuals should consider other social media sites other than Facebook as well. It should be noted that the social media module took place solely on Facebook, where middle-aged to older-age men are less likely to be recruited from. Also, it would be important to evaluate other social media sites to essentially see which sites nurse practitioners prefer to learn from. This way you can enhance learning for the majority. Reducing unnecessary antibiotic usage and in turn reducing the number of antibiotic resistant organisms the practitioner might encounter daily could be a significant implication for the profession. Additionally, there is the potential for patient satisfaction scores to improve, given that they were appropriately treated instead of prescribed a medication that could cause a side effect. And satisfied patients could significantly boost the nurse practitioner's practice through referrals. And so for the importance of business and patient health outcomes, educating nurse practitioners on appropriate antibiotic prescription practice has significance. And also, it has the potential to improve patients' health outcomes and reduce their costs. In conclusion, this project demonstrated improved nurse practitioner knowledge related to upper respiratory infections and appropriate antibiotic prescribing practices, the exception to this trend being a single question in which most participants incorrectly indicated that antibiotics reduced severity of upper respiratory infections. The project did not, however, change the way most providers practice. Exactly half of the participants deemed the social media education module useful for changing their prescribing practices, while the other half did not. I just want to say thank you again to my DNP committee, as well as to everyone listening. If you have any questions, please reach me at this email address. And here are my references. Thank you again for your time.